So, good evening. So I have nothing to disclose, and these are my resources. So the objectives of my speak today is to describe the clues that can help us as a practitioner in the diagnosis and treatment of rheumatological disease, and to identify most, common false information that might affect our daily practice. So we'll start with pearl number one. Patient with retinal vasculitis should not be evaluated thoroughly for systemic vasculitis. The ophthalmologists use the word vasculitis different than us. For them, any patient who have a fluorescein diet leakage from the retinal arteries is considered vasculitis. While we use it differently, we usually depend on the angiogram, we depend on biopsies to diagnose vasculitis. And we have to know that the microvasculature of the retina and blood vessels is typically different than the systemic vasculitis or the systemic blood vessels that we see in patients with systemic vasculitis. And retinal vasculitis is a rare manifestation of systemic vasculitis. This leads us to pearl number two. If an ophthalmologist reports that your patient with Wigner has retinal vasculitis, the correct diagnosis is probably an infection. We use a high dose of steroids, we use a lot of immunosuppressive medication, and this increases infection. So if your patient with vasculitis say that he has blurred vision, and the ophthalmologist say that he has retinal vasculitis, you don't have to think of the systemic vasculitis, you have to think of infection, and mainly viral infection like CMV, herpes zoster, varicella zoster infection. And the treatment in this case is antimicrobial medication and to reduce the immunosuppressive medication. This is a picture for a patient with CMV retinitis, and you can see that the fluorescein is leaking and there is patches of blood hemorrhage. And this is what they see usually. Still with the eye, pearl number three. Pain is a typical manifestation of scleritis, but not typical for episcleritis. I'm sure that most of you had patients who have red eyes and the patient has RA, and then you ask yourself, is this serious or not? So if the patient ask the patient if he has pain or not. If he has pain, this is scleritis. If he doesn't have pain, it's most probably episcleritis or conjunctivitis. And it's very hard for us to differentiate between episcleritis and scleritis by just looking at the eyes. Even for ophthalmologists, they usually use a slit lamp examination to know if this is scleritis or episcleritis. The question is, why is it important to know that this is episcleritis or scleritis? If an ophthalmologist refers you a patient with scleritis, then there is a 50% chance that this patient has rheumatological disease. While episcleritis is not common, there is a small amount of patient that has rheumatological disease and episcleritis. And the second reason is that patients with scleritis, if you leave them, they can become blind. They can have corneal melt, and then this can cause the visual loss. So scleritis is a serious condition that you should seek an attention as soon as possible, while episcleritis is a benign thing. This is a patient with scleritis who developed corneal melt. As you can see that the sclera is melted away, and you can see the chorea behind the sclera. For episcleritis, the treatment is observation or artificial tears. Sometimes you have to use topical NSAID or topical steroid, but for scleritis, you always have to use topical steroid and sometimes topical NSAID. And if they don't respond, you have to use strong immunosuppressive medications like rituximab or cyclophosphamide. So always ask about the pain. If patient has redness and pain, this is a serious condition, and you should call the ophthalmologist as soon as possible. Pearl number four, visual loss recovery in giant cell arthritis patient is most likely not because of glucocorticoid. I know that we usually get consultation from ER physicians. Patient has GCA symptoms. We give patient steroid. After 1 or 2 hours, visual loss, patient recovered, and we become happy about it. The results are jumping, and we brag about it that we saved the patient's eyes. But actually, we actually didn't do anything. Patients with giant cell arthritis frequently experience episodes of amaurosis fugax Amaurosis fugax is Latin for transient visual loss. So this patient, if you leave them alone, they will recover anyway. So, and if the patient develop ischemic visual loss, there is almost nothing you can do about it. The visual loss will be permanent. So why we give a steroid? We give a steroid to treat patient symptoms and to prevent complications of giant cell arthritis, which is ischemic stroke or ischemic visual loss. And if you have a patient with giant cell arthritis that has visual loss for a few days and you give them a steroid and patient recover, then most likely they don't have giant cell arthritis. You have to rethink the diagnosis again. Moving from the eye to the skin, the malar rash of SLE is not transient. I'm sure most of you also have a referral from internist, inpatient, has vague symptoms, arthralgia, and they saw malar rash. And when you come and see the patient, you don't see the malar rash. And the patient tell you that the malar rash disappeared 1 or 2 hours ago. This is not malar rash. Malar rash is an inflammatory condition. Usually the skin is raised, and inflammation takes time to resolve. If the patient tell you that they have intermittent malar rash or malar rash disappeared 1 hour ago, then you have to think of other causes, flushing, rosacea, cellular urticaria, or other skin condition. The second more important thing is that patients with malar rash, they are sick patients. You can't see a patient that's doing well except malar rash. If they have malar rash, they're usually sick, and they have other manifestation of lupus. The first myth of today, most nodules in patients with lupus are from lupus paniculitis. Lupus paniculitis is a rare condition, and if you have a patient with SLE and nodules, you have to think of other causes like vasculitis, erythema nodosum, lividovasculopathy, or infection. So, and lupus paniculitis actually usually involve the malar regions and lateral deltoid fat. Usually start as a nodule, then it leaves depression. And half of the patients, they will have overlying skin changes like hyperpigmentation, scaling, or erythema. And they used to see a lot of patients with these depression over their scalp and hyperpigmentation and think that they have discoid lupus. But now, after I noticed that this is a myth, then I have to think that they might have lupus paniculitis at one time, and it's not a discoid lupus. Still with the skin, peril number 6, the presence of discoid lesions below the head and neck region is associated with increased risk of developing SLE. Patients with discoid lupus that's limited to the neck and face or scalp, they have only 5% chance of developing SLE. And I had a patient who has discoid lupus referred from dermatology clinic. She's on methotrexate, and I followed her for a long time, for 2 years. After 2 years, she said, "Why am I following you?" And it's true that I wasn't doing anything. I was just trying to find any signs or clues that the patient developed systemic lupus. But this is only true for discoid lupus involving the scalp and the face. If it's involved the region below the neck, there is a higher risk of developing SLE. And there are other several risk factors for developing systemic lupus in patients with SLE. As you can see, that generalized discoid lupus found to be 2.2 times more likely to develop SLE compared with the localized discoid lupus. And other risk factors include arthritis, peringual telangiectasia, anemia, high ANA titer, leukopenia, high ESR. So if you have patient with discoid lupus and has these manifestations, these are the patients that you have to follow in this clinic. But if the patient does not have these risk factors, you just have to see them for 1 or 2 times and then refer them back to the dermatology. You don't have to follow them on frequent basis. Second myth today, dilated capillary loops are observed only in patients with systemic sclerosis. Well, it's true that systemic sclerosis is the most common cause of dilated capillary loops, but there are other connective tissue diseases like mixed connective tissue disease, SLE, dermatomyositis, and rheumatoid arthritis that they can have dilated capillary loops. And one interesting thing that these dilated capillary loops can disappear sometimes over time. And when it disappears, it's not always a good thing. It might actually indicate the progression of an obliterative vasculopathy in patients with systemic sclerosis. So we shouldn't be happy if the dilated capillary loops disappear. Pair number 7, psoriatic fingernails, onycholysis, and hyperkeratosis are associated with high risk of PSA. We usually ask the residents or fellows that they have to count how many pits and if there is pittings, but we don't ask him if the patient has onycholysis or hyperkeratosis. But actually, any fingernail disease is associated with the high risk of PSA. This is a study published last month which showed that fingernails disease were more common in PSA of about 69% versus 42% in patients with psoriasis. And onycholysis has an odd ratio of 2.34 of developing psoriatic arthritis. And also hyperkeratosis has a high odd ratio. So any fingernail disease can be associated with high risk of PSA. And it's not only pitting, nail pittings. Pair number 8, remember to consider DISH before diagnosing advanced ankylosing spondylitis. Patients with ankylosing spondylitis, they usually start with inflammation and bumbo spine, but over time they can develop degenerative changes in addition to the inflammatory changes. They can have osteophyte in addition to syndesmophyte. And they start to have mechanical back pain that they can overlap with the DISH. They can have similar postures. They can also, the physical examination is not helpful in differentiating between the two conditions. Both conditions, they can have reduced motion of cervical spine and lumbar spine, and they can have reduced chest expansion. Some of the clues or some of the things that can differentiate between the two conditions: history. Ankylosing spondylitis, asking about when did they start to have back pain. They usually start younger age compared with DISH, where it starts usually in 50s. Look at the spine. If the disc space is preserved, this is most likely ankylosing spondylitis. If it's decreased, it's most likely ankylosing spondylitis. If it's normal, it's most likely DISH. And look at the sacroiliac joints. Patients with DISH, they can have degenerative changes on the sacroiliac spine. They can have osteophytes. But in patients with advanced ankylosing spondylitis, they can have either erosions or complete ankylosis. Pair number 9, interpret sacroiliac joints MRI carefully. I learned this the hard way. I admit that I treated patient with the report of bilateral sacroiliitis, and then when I reviewed the MRI later with after starting, of course, NSAID and biologic, and reviewing the MRI with the radiologist, he said this actually is not sacroiliitis. And remember that the SAS definition of sacroiliitis is not specific. The usual definition is either 2 bone edema lesion in 1 slice or 1 bone edema and 2 slices of MRI sacroiliac joints. And based on this definition, you can see sacroiliitis even in normal people. You can see it with any patient with chronic back pain. This is an abstract was presented in 2018 by Euler, and you can see that in the left side, based on SAS criteria, you can see sacroiliitis in healthy individuals, in patients with chronic back pain, with runners and athletes, and you can see it in up to 57% in postpartum patients. When they redefined sacroiliitis as bone edema extend more than 1 centimeter from a sacroiliac joint, the specificity increased. And you can see in the right side, there's none of the healthy individuals or those with chronic back pain or those with who are athletes has sacroiliitis based on this condition. And there was only 1 out of 7 patient or postpartum patient has sacroiliitis based on this definition. So maybe the SAS, hopefully they can redefine, change the definition of sacroiliitis and make a definition that has a good sensitivity and good specificity. Pair number 10, PFT alone misses most patients with systemic sclerosis, ILD. Don't depend on PFT to diagnose ILD in patients with systemic sclerosis. This is a cohort from Zurich where they included patients with systemic sclerosis and ILD, and you can see that 62% has evidence of ILD in CT scan, HRCT, but they have normal PFT, compared with only 37% of patients who have both HRCT and PFT suggested of systemic sclerosis ILD. So don't depend on PFT alone. Always do HRCT as well as PFT. Scleroderma, a normal echocardiogram in systemic sclerosis does not exclude pulmonary arterial hypertension. We usually get false positive echocardiogram. The cardiologist said that this patient has pulmonary arterial hypertension, and when we send the patient to right heart cath, it turns that they don't have. But we also can get a false negative echocardiogram. And remember that the echocardiogram is operator dependent, and when they measure the pulmonary arterial pressure, they actually look at the tricuspid regurg. And you can understand that patients, if they have right side heart failure, the tricuspid regurg decrease and they can have normal pulmonary arterial pressure. So if you have also a patient with severe pulmonary arterial hypertension and the repeated echo showed decrease in pulmonary arterial pressure or normalizing of pulmonary arterial pressure, you have to think of right side heart failure. So what should we do? Use detect algorithm. This is detect algorithm, and you can see that the step 2, they measure tricuspid velocity, and they also measure right atrium area. And both step 1 and step 2 has sensitivity of 100%. So if you have patient with pulmonary arterial hypertension and you use detect algorithm, there is a 100% chance that you will detect that the patient has pulmonary arterial hypertension. Third myth of today, the presence of rimmed vacuoles and muscle biopsy is diagnostic of inclusion body myositis. You can actually see rimmed vacuoles in different conditions. You can see it in oculopharyngeal myopathy, rigid spine syndrome, and various neurogenic diseases. And you can also see it actually in polymyositis. So rimmed vacuoles alone does not diagnose patient with inclusion body myositis. You have to use the Griggs criteria, which has both clinical and laboratory criteria. And when you look at the muscle biopsy criteria, you have to have 3 things to say that this patient has inclusion body myositis. In addition to the vacuoles, you have to have a monocellular infiltrate of non-necrotic muscle fibers, and you also have to have either amyloid or tubulofilaments. So you have to have 3 things in the muscle biopsy to say that the patient has inclusion body myositis. Pair number 12, inflammatory myositis, patient with positive anti-Jo1 antibody may have negative ANA. Remember that anti-Jo1 antibodies and anti-synthetase antibodies are cytoplasmic antibodies. They don't affect the nucleus. This is why you can have anti-synthetase syndrome with negative ANA. And you can see the 2 pictures which show the anti-synthetase antibody, they spare the nucleus, while the ANA antibody at the bottom, they include the nucleus. If you have a patient with inflammatory myositis and anti-synthetase syndrome and the ANA is positive, you have to think either there is a coexistence, a connective tissue disease like overlap, or there is a presence of other myositis-specific antibodies like anti-MI2, anti-P155, 140, which is called now TIF, or the anti-polymyositis scleroderma autoantibodies. Pair number 13, don't be fooled by normal complements level during pregnancy. So if you have patient with lupus and the complements are normal, she might be actually having low complements. Complements increase during pregnancy by up to 50%. So having a normal complements is actually might indicate that the patient is serologically active. And you have to take history, you have to do other blood tests to make sure that the patient does not have active lupus. And you should not depend only on complement to decide whether the patient has active lupus. You have to take the patient as a whole. Pregnancy, pair number 14, pregnancy losses occur despite low molecular weight heparin and aspirin treatment in 25% of women with antiphospholipid syndrome. So if you have 4 women with antiphospholipid syndrome and you give them aspirin and heparin, one of them will have pregnancy loss despite the treatment. It's quite disappointing, but it's better than those who don't receive treatment, which they have 90% chance of pregnancy loss, or those who have aspirin alone treatment with 40% chance of pregnancy loss. And unfortunately, there is no second-line treatment. There are other possible treatment that you can use. You can use hydroxychloroquine, you can use IVIG, you can use prednisolone. Again, these optional treatment, there's no strong evidence behind them. Pearl number 15, ibuprofen is the NSAID of choice for women who are breastfeeding. All NSAIDs are safe breastfeeding, but ibuprofen is the best choice, and it's because it's excreted in small amount in the breast milk. It has short half-life, and ibuprofen actually is approved as therapeutic medication for children. Fourth myth today, exercise and physiotherapy is contraindicated in patients with inflammatory myopathy during the initial phase of treatment. And when I was a fellow, I had a patient with dermatomyositis, and the consultant told me, don't start physiotherapy until CK is normalized. But the second week, another consultant came and said that this is wrong, you can start physiotherapy as soon as possible, and he was right. And this is a long-held belief, and this is a false. And I think this is because it showed that exercise increased CK, but there are several studies that's reassuring and showing that you can start physiotherapy as soon as possible, and it improves the strength and to improve the quality of life. So don't wait for CK is normalized. This is a study where they did the muscle biopsy after 7 weeks of physiotherapy, and when they did muscle biopsy, there was no increase in muscle inflammation. Pearl number 16, many mothers who deliver babies with neonatal lupus have no established connective tissue disease at the time of their child's birth. About 66% has no recognized symptoms of connective tissue disease when they deliver their babies. And you can see here is up to 70%. They either asymptomatic or they don't have definitive connective tissue disease at the time of delivery. And when you follow this patient, there's only a small amount or small percentage of patients who develop full systemic disease. Sjogren's syndrome, 28%, SLE, 90%, and some patients can develop also autoimmune thyroiditis. Final pearl. Combining 2 biologic medications are not always wrong. We had several studies in the past that showed combining 2 biologics increased risk of infection. There's several studies combined abatacept with etanercept with rituximab, or abatacept with rituximab, and showed the high risk of infection. And there was also several meta-analyses that say that there's a high risk of infection with combined biologic treatment. But now we have a new biological treatment. We have interleukin-23 and interleukin-17 inhibitors. They are very safe. They have no TB reactivation. Most common infection is actually upper respiratory tract infection. This is an abstract which included patients with moderate to severe ulcerative colitis. What they did, they combined golimumab, which is an anti-TNF, and guselkumab, which is an interleukin-23 inhibitor. And they compare it to guselkumab monotherapy and golimumab monotherapy, and the combined medication works. The patients were more likely to achieve clinical remission and clinical response compared with the monotherapy. And what's important, that the infection rates were similar between the 3 groups. And this reminds us for a study for rheumatoid arthritis in 2019, where they combined bimezicumab, which is interleukin-17, and certezolumab. In this study, of course, it's failed because we know that interleukin-17 does not work for rheumatoid arthritis. But in this study, there was no high risk of infection or higher risk of infection in the combined treatment compared to certezolumab monotherapy. There is now ongoing trial of combining anti-TNF and interleukin-23 for psoriatic arthritis. So sorry for the delay. Always review your pearls and don't believe your consultant. They might be right. They might be wrong, sorry. And always make sure that these pearls actually based on observational trials. So maybe future studies showed that what we think are pearls are actually fake pearls, and this is why we have to update ourselves. Thank you.